Learned some things about bowel today. Clearly, you're going to do more today. But in this case, we have a 29-year-old who comes in to see because of gas and diarrhea. What he wants to know is does he have lactose intolerance that's causing his gas and diarrhea? So he has a number of questions. Does he have lactose intolerance? Does milk cause his symptoms? Does he have lactase deficiency? So can you think of ways that you could address these problems? How about the second question? Does milk cause the symptoms? How would you address that? Okay, so a clinical trial. So we do this often in medicine because we don't always know what's causative in a patient or what, and sometimes we don't have sophisticated tests or we have very expensive sophisticated tests. So in terms of why would lactose or milk be causing his symptoms? Okay, so is he having gas and diarrhea because of carbohydrate malabsorption, and in this case specifically lactose malabsorption, and lactose is only found in mammalian milk, in theory. It can be put in anything, I guess. Milk chocolate has it. So therefore, you can do a clinical trial of saying, if you give him lots of milk, does that make his symptoms worse? What's the flip side of that trial? Avoid it, right. And actually, sometimes it's easier to have people avoid things and see if the symptoms go away completely. And then you can do a re-challenge. Do the symptoms come back? And the nice thing about carbohydrate malabsorption is it's a pretty reliable set of symptoms that he can observe. So you can put him on a dairy-free diet for a couple of weeks to see if the symptoms completely go away. And then you can say, okay, now do a few days of gorging on milk and ice cream and see if the symptoms come back with a vengeance. That's actually pretty good data. So it's not a randomized, but it's a wash-in, wash-out clinical trial with N of 1. And for carbohydrate malabsorption, if you can get them to obey your instructions, which is problem number 1, you can actually get really good data. And when patients make this discovery, it's like a little light bulb went inside their head. They say, oh, yeah, okay, that was it. And then it's up to them to decide if they want to give up milk and ice cream or they want to have gas and diarrhea. Because it doesn't cause any damage to anything. It might be damaging to your social life, but that's an independent decision on that one. Okay. So how would you answer the question, does he have lactase deficiency as a cause of his lactose intolerance? So another clinical trial would be to give him milk that's been pre-treated with lactase. And you can buy that enzyme now, and you can buy milk that's been pre-treated. So that's another clinical trial. There are research methods that allow you to actually measure lactase in the brush border of the small bowel, but those are really pretty much research. Okay. And we'll talk today in the lecture a little bit more about something called a lactose hydrogen breath test, which actually looks at production of hydrogen gas when bacteria metabolize different carbohydrates. In this case, you would give the person lactose and see if they made a lot more hydrogen gas versus giving them something like glucose, where they wouldn't make a lot of gas. You usually don't have to do that, though. The clinical trials work really well. Okay. This is another patient, 55-year-old man, comes in because of diarrhea. Began in the last year. He can't tell you exactly when. He has 3 to 5 loose stools during the day, none at night. And so this when you talk to him, this satisfies your definition of diarrhea. He doesn't have abdominal pain. He hasn't lost weight. He does have heartburn. And he takes antacids and has a normal physical exam except for loose, watery stool, which again provides you the information that he truly is talking about diarrhea. So what's your differential diagnosis for his diarrhea? Okay, so actually you need another piece of history from him. What antacids are you taking and how much? So what type of antacids might he be taking that could cause diarrhea? Yeah, they have to have a magnesium in them. If they're aluminum hydroxide or they're calcium carbonate, which is what Tums and Rolaids are, those actually tend to cause more constipation. Sometimes you actually have to have the patient bring the bottle in and show it to you, and you read the fine print. Okay, so number one possibility is something that he's taking. And what would you do to test that out? Yeah, the cheapest test is to tell him to stop the antacids, you give him something else, and see if his diarrhea goes away. That's easy, that's cheap, that's non-toxic. What would you give him for his heartburn? Doing a study in the effects of gravity on the round object. Okay. So, but he's going to tell you, okay, but if you take my antacid away, my heartburn's going to come back. So what are you going to do about that?
Change acids.
So you can change that acid. You can tell him to take one that has calcium in it. What else can you do? Yeah, you can actually treat him with an H2 receptor antagonist or a PPI to take care of the heartburn if the alternative antacids don't work or he hates them. Patients sometimes decide there are certain things they just don't like. Okay. Now, what if you take away his antacids completely? He's compliant. He's doing what you told him to. You put him on, say, an H2 receptor antagonist. He comes back and says, Doc, my diarrhea got no better. So you bombed out on your first differential, but it was the right thing to do. So now you need another strategy. Yeah, so you can ask about his diet and find out, is there anything else in his diet that could be causing diarrhea? That's history. It's cheap. It's easy to get. What other things did you ask about? Okay, so has he traveled? Now, he's had his diarrhea for a year. When you travel, we're generally thinking infectious diseases. Can anybody think of an infectious disease that would cause diarrhea that would last for a year? Giardia is probably about the only one. Now, amoebae, if you go to Mexico and eat raw salads and get amoebae, you can get an acute dysentery. You can carry that bug for a long time, but it generally doesn't produce long-term diarrhea without blood. So Giardia is the one parasite, and it's ubiquitous all over the world, whatever. So there aren't too many infectious diseases. Now, if this guy had only had traveled 2 weeks ago, or a week and a half ago, or 3 weeks ago, you've got a whole universe of infectious diseases. So, other than infectious diseases, what other things could cause loose stools for about a year in this guy? Okay, so we get back to diet. What kinds of foods or drinks would you ask him about that might be causing an osmotic diarrhea? We've got things that have sorbitol in them. Yeah, and so what do you ask him? If you say, do you drink a lot of high fructose corn syrup, most of your patients will probably look fairly blank. Yeah, and it's the regular sodas, not the diet. How much? And people say, oh, a couple a day. And then you say, okay, is it the 6 ounce, the 8 ounce, the 24 ounce, or the 32 ounce? Because it comes in big bottles. You'd be surprised if someone will tell you that. I hate to think of their budget for the year for soda. So sodas, diabetic candies, sugar-free chewing gum, things like that. So you can take a history, you find out, no, he's not doing any of those things. So now you've eliminated all the things people put in their mouth that can cause diarrhea. You've got a bunch of other causes of diarrhea. So where do you go next? So you can analyze the stool to get some hints there. So we've told you it's 3 to 5 times a day. It's not at night. It's fairly loose, but he doesn't see any blood, and he doesn't really have much in the way of pain or weight loss. So what types of diarrhea? Thinking of the pathophysiology. Does this sound like an inflammatory diarrhea? No. And I'm not saying it can't be, but it doesn't sure sound that way. Okay. How about rapid transit diarrhea? So that's on your list. When do people often get diarrhea with rapid transit? They can often get it fairly soon after they eat. So that's a history question you can ask. And if he says, oh yeah, half an hour, 45 minutes after a meal, I'm in the bathroom, that would be fairly typical of that. It's something that you would be a little supported. It's not proof, but it's supported evidence. And then you can look at the stool to see if you can separate out secretory, osmotic, things like that. So you can then start to investigate some areas. And it gets really complicated after that to work out. Okay, so his diarrhea did continue after they stopped the antacid. And here are his stool electrolytes and his stool osmolality. So the first question is, what is his stool osmotic gap? You had to do mathematical problems with electrolytes in renal. So I'm just sending you back to those days. Okay. So how do I calculate the stool osmotic gap? So sodium and potassium added together is 130. Times 2 equals 260. And the stool osmolality, 295. So the difference is 35. Is that a high gap or a low gap? Low. So what types of diseases are you thinking this is? What's his sodium and potassium? Which one's the prominent cation? So a high sodium with a normal osmotic gap. Secretory diarrhea. Yeah. So you've now worked your way through that part. And what diseases can cause a secretory diarrhea? Something's got to be secreting in the bowel. You have to have something that's causing secretion. Well, look at your differential diagnosis for that, because now this is what you're going to pull up, is that list of possibilities. So there can be a toxin. Now, those are usually from bacteria, and they're usually acute. We've already said this is a chronic disease. There can be low-grade inflammatory diseases. You'll hear some more about that today. It can cause a low-grade secretion. You can have malabsorption of bile acids or fatty acids that can cause it. Certain laxatives can cause it. And then there's hormone-secreting tumors. And there's always an idiopathic. And one of those idiopathic is probably a post-infectious process. Somebody had an infectious diarrhea, some reason the secretory process got turned on and it just continues. And we do see that occasionally, but there aren't any specific tests for it, and the bowel usually is perfectly normal. So then you've narrowed down from the universe of diarrhea to at least a subset. So this is just to remind you of the fecal electrolyte values. And I wanted to just go through some of those and have you take a look at these for some practice today to try to start thinking through how do we analyze these, what information can we pull out of it. So this is a patient who comes in. Does this person have diarrhea? So you look at the volume, 3 liters a day. Does that fit your definition of diarrhea? Okay, so we're heading down the right pathway. Okay, and plasma and stool osmolality are almost identical, which they should be. So what type of diarrhea do you think this is? Okay, so it's a high sodium, and the osmotic gap, sodium plus potassium is 135. Multiply by 2, that's 270. That's pretty close to this, so there's no gap. High sodium, low gap, this is going to be secretory diarrhea. Go to the next one. The fecal pH, by the way, is something that the pediatricians tend to use. Normal fecal pH is a little bit on the acid side, but not much. Can you think of processes that might make the stool more acid? When you ferment carbohydrates, you get short-chain fatty acids and you get small acids. So carbohydrate malabsorption, which the pediatricians are really looking for because they get the babies with the abnormalities in carbohydrate transporters in the gut. So they would be looking at this. So you can't measure an exact pH, but it's a range. If you're over about 5.5, that would be considered normal. If you're under, it's acid, and then you have to figure out why it's acid. It's usually not because people are drinking hydrochloric acid. They're already doing that. Okay, here's a patient. Does this person have diarrhea? So 1.3 liters a day, 1,300 mLs. That's abnormal. That's about what the ileum is putting into the colon every day, but it shouldn't come out the other end. Plasma and stool osmolality are equal. How about the electrolytes? Do we have a prominence of either sodium or potassium? And are either of them high enough to account for a lot of these electrolytes? Okay, so this is where you want to look at that and say there's something missing here. I can't account for a lot of the osmolality from the sodium and potassium. So your osmotic gap is going to be helpful here. So what's the osmotic gap in this person? We have the 22 plus 26 equals 48 times 2, 96. And you've got a plasma osmolality of 295. The gap is 199. Normal or abnormal? Very abnormal. Okay. So there's a huge osmotic gap. So what kind of diarrhea is this? It's an osmotic diarrhea. Now, then your question is, what's the osmotically active material there? What can you measure to try to work it out more? So you can try measuring other ions. Which one is easy to measure? So magnesium is the one that's the easiest, but you can also ask for phosphate. Some laxatives contain phosphate. But in this case, you ask them to measure the magnesium. Magnesium is extremely high. Normal is under 15. And therefore, there's a large osmotic gap. There's a very high magnesium concentration. And remember that magnesium is a cation, so it pulls two monovalent anions with it. That'll probably account for all the osmotic activity. So what question do you go back and ask the patient? What are you putting in your mouth that has magnesium in it? So this is somebody who's consuming a lot of a magnesium-containing product. You just have to figure out what it is, and that's causing their diarrhea. Okay. Case number 3. Does this person have diarrhea? No. That's 280 grams a day of stool, perfectly normal. If this patient is telling, is there anything wrong with the electrolytes? Not really. No, those are perfectly within the range. Actually, you probably wouldn't be able to get the lab to measure electrolytes because it's solid stool, and only liquid will go through the automatic analyzers. So it would probably come back from the lab as stool solid, test not run. That's actually one of our diagnostic questions in GI. We ask the patient to submit stool samples when they're complaining of diarrhea, and the lab sends it back saying solid stool. We say, okay, we have a problem in the patient's perception of their symptoms. So no, this is perfectly normal, and then you have to question the patient further to try to figure out what symptoms is it that's really bringing them in. Is it tiny amounts of stool frequently, and there's something in the rectum that's giving them urgency? What is this? Okay. So how about this patient? Does this person have diarrhea? Yeah, absolutely. And what do you think of the electrolytes? Yeah, there's things that are missing. When you add up that sodium and potassium, you've only got 60 milliequivalents. So, we got 295. So sodium plus potassium is 60 multiplied by 2 is 120. You've got a gap of 175, which is very high. So again, osmotic diarrhea is likely to be present. So what else do you want to measure? You also are missing a whole lot of anions there. You look back here, well, chloride's fairly low, normal. Okay. So in this case, you had a case of magnesium overdose. So magnesium's an easy thing to measure, but in this case, the magnesium level is really low. So you happen to have sent off a stool osmolality and a fecal pH. So magnesium isn't the problem here, but there's clearly something else from your osmotic gap. And now you have an acid stool. And you also have this very interesting fact that your stool osmolality, when it got to the lab, was elevated. Now, I've told you that as the stool comes out of the human body, it cannot be hypertonic. So something happened between the time the stool was passed and the time the lab assayed it, which is usually a number of hours later with things sitting around at room temperature. So with a low pH, what type of osmotic diarrhea do you think this is? Yeah, so you're thinking this might well be a sugar in there, a carbohydrate. When you pass the stool, it's got bacteria in it. It's got sugar in it. Bacteria sit around at room temperature. Do they die? No. So what happens is as the stool specimen is on its way, working its way through the lab and getting there, and it can take a number of hours, whatever remaining carbohydrate is there in the stool, the bacteria may continue to break down. And they may break it down into small molecules. So if you take one sugar and you get two carbon organic acids, you've now generated extra osms, but it's outside the body, so there's no water being added. So the one time you can get a high stool osmolality is from carbohydrate malabsorption, and the specimen's sitting around for a number of hours. Otherwise, stool osmolality is always plasma. But you already were suspecting there was something else there, and you have an acid pH. So those are just clues to think, okay, this life may be more complicated than this, but there's at least a few clues here. Let me think of a carbohydrate. So just as you can actually measure some sugars in stool. They do this in pediatrics. What they do, it's a very, very old test. It's a dipstick, and it says, do you have reducing sugars in the stool? And these are the sugars that are reducing sugars. But some are not reducing sugars, so it's not perfect. And they usually can't measure the individual sugar in there. So you're really looking at the fact that you've got missing osms, you've got an acid stool, and this to tell you there's a sugar there, you're just not sure which one. Okay. Here's another patient. Does this person have diarrhea? Okay. What can you tell? Look at the electrolytes. Is there anything that looks funny with the electrolytes? Yeah, they're all low. So you might first think, okay, this is an osmotic diarrhea and it's something we can't measure. So you send off a stool osmolality and it's low. And so how can you explain a low stool osmolality? They didn't drink the water. They put it in the stool container. Somebody added water. This happens more often with urine tests, but it can happen. People can add things. There are people who have factitious diseases. So there really isn't any medical way you can have a low osmolality. So you would look at this originally and think, oh, I'm thinking about an osmotic diarrhea, but it's not fulfilling all the criteria, and you've got to look at this and say, okay, did somebody add water to the stool? That's about the only way you can dilute something aside. So urine can be very concentrated and very dilute, but stool and other bodily fluids should be isotonic, and if they're low, something got added after the sample was obtained. All right. Yep. And it could be that urine was mixed with it as well, especially if there's dilute urine. And some people have great difficulty separating the two, especially if they're having diarrhea. It's a tough problem with kids as well. And so one option is the person didn't add it deliberately, but that urine got mixed with it when they were trying to collect it. So you really can't use that data then to help you. Okay. Got one more here. Okay, is this diarrhea? Not diarrhea. Okay, so it's diarrhea. And what do you think of the electrolytes? So it's a high sodium with a normal osmolality. Is there an osmotic gap there? Okay, this is 145. 2 times that is 290. There's no osmotic gap. So what type of stool is this? Yeah, this is looking much more like a secretory diarrhea. So the only other caveat here is that your 2 anions, the anion is really, really low. So for a secretory diarrhea,
you tend to have higher chloride because that's what's being secreted. Normal stool, most of the anions are things like phosphate, sulfate, organic anions, things like that. You can't really measure them. In this case, you've got a very high sodium potassium, almost no chloride. So this could well be a secretory diarrhea, but one other option is this patient's taking a lot of an anion that is osmotically active. The most common one is phosphate. You go down the laxative aisle in the store, and you see Fleet's Phosphosoda. That's phosphate with a mixture of sodium and potassium, and it is a laxative. And so when you're looking for things and they don't quite fit and you can't find a secretory diarrhea, you can always go back and relook at these and think about phosphate as an option. But that's really tough to work out, so it's not something that I would look at those first electrolytes and I'd say, let me think about secretory processes while I'm grilling the patient on what they're taking. And if I really get stuck at the end, then go back and look at all this again and say, is there something else that I'm missing? And phosphate laxative would be the one thing. Okay. So... And then this is the other one that we just wanted to look through, which is a secretory diarrhea, where you can see here that the sodium and potassium are high, but the chloride is also fairly high compared to this one. Okay, so we need to stop here, take a break, and we'll start with the malabsorption lecture at 10 after.